Welcome everybody, and thank you for joining. So today I'm going to talk about data from the 2025 surveillance report and some of the products that are in development. As I'm sure most of you know, the network has been collecting and publishing birth defects surveillance data since the year 2000. Data are currently submitted from surveillance programs every other year, but that cadence has varied over time. The submitted data get cleaned and analyzed, and findings are presented in a variety of products, a few of which I'll describe in the following slides. The most recent data call went out in July of last year, requesting data on 47 birth defects for deliveries occurring from 2018 through 2023. The 2023 data were collected for internal evaluation purposes and are not included in any of the data products I'll discuss on the next slides. So in the last data call, data were submitted from 40 US birth defects programs, colored in the darker blue. Data were cleaned and reviewed by CDC staff, and resubmissions to address errors were collected and processed. This was a huge lift by everyone involved at the program level, the Surveillance and Data Committee, and CDC, as the received data encompassed almost 600,000 defects. So the first product generated with the new data were the 5-year national estimates. We prioritize this product as there has been a focus here at CDC and more broadly across public health to make data available faster. And we focused on just the estimates that would be shared on the website. And we were able to get those out pretty quickly despite the government shutdown in the fall and other obstacles. The national estimates have historically been calculated using data from a subset of programs. The group of included programs has varied over time a little bit. In the more recent years, the group was limited to programs conducting active surveillance for defects for all pregnancy outcomes. Since the active-passive program determinations have become a little less clear with the increasing availability of electronic medical records, we decided to include programs that ascertained all pregnancy outcomes and conducted medical record abstractions, as reported in the performance summary that accompanied the call for data. By and large, those were the same programs formerly considered active surveillance programs. Estimates were generated for the 33 defects included in the previous national estimates manuscripts. And we presented the updated estimates to the Surveillance and Data Committee in early January and posted to the CDC website shortly thereafter. So the second product that we've been working on is what we are calling a data brief. This is a new product for us, but it's something that we are hoping will become routine for every data call. The intent of this document is to present some additional data to accompany the national estimates for easy reference through a website posting. This mechanism allows us to make that data accessible much more quickly than we have traditionally done through peer-reviewed manuscripts. And if we find this to be successful, we'll be able to put out subsequent briefs with each data call faster since the content is now largely determined. The data brief includes the same 11 programs and 33 defects in the national estimates calculations, and I'll get into the details of the document and the findings in later slides. As in previous years, state prevalence tables will be generated for posting on the network website. There's an example on the right side of the slide here, which I know is unreadable, but these are located on the network's website at the address at the bottom of the screen if you would like to view those. The new tables are currently being generated. As in the past, they will include all 47 defects that were in the data call and present counts and prevalence overall by maternal race ethnicity and by maternal age for a few defects. The tables will be sent to programs for their approval prior to posting, and programs can note where the data need to be suppressed to meet their regulations. We are considering a possible change to suppress all cells less than 5 unless a jurisdiction has stricter suppression rules. This possible new policy is being discussed by our network colleagues. We anticipate that there might be multiple other analytic projects undertaken with the new data, but those are largely to be determined. We do have one analysis in process to assess annual trends and prevalence of selected defects from 2016 through 2022, which we plan to generate into a manuscript for peer review publication later this year. Any additional projects and their prioritization will be discussed by the Surveillance and Data Committee. So now I'll turn to kind of the main topic of the webinar today, which is to review the data brief that's been developed. And before I get started, I just want to acknowledge my co-authors on this project, Tori, Adrian, and Laura. This was very much a group effort. So as I said earlier, really the intent of the data brief document is to present some additional prevalence data to accompany the national estimates for easy reference. So the document includes prevalence by year, maternal age, and maternal race ethnicity for each defect. And as I said already, we plan to share the document through a web posting, which we can complete much faster than a traditional peer-reviewed manuscript. The analysis was limited to the data reported from the same 11 programs used to generate the overall 5-year national estimates. Again, these are programs that ascertained all pregnancy outcomes and conducted medical record abstractions. Given the way that the data are reported to the network, infants with multiple defects are included in each applicable defect category. Therefore, the data don't allow us to assess how many infants have multiple defects or to determine which defects are associated with specific syndromes. We have not conducted any statistical analyses to compare different groups. Our intent with this document is really just to make the data available for reference. We anticipate that the network's data committee and other groups might use this document to identify differences or unexpected findings that might be the focus of later analyses. Those of you that are newer to the birth defect space might wonder why we limit the programs included in the national estimates calculations. The variations across birth defects programs in their surveillance methods lead to substantial variations in prevalence estimates at the program level. And I just wanted to share this figure to kind of highlight the high variability that we do see across the programs. So each row here represents one defect, and each dot represents the reported prevalence from one of the 40 programs that responded to the data call. So on the top row here, the state-specific prevalence for cleft palate alone ranged from 4.0 to 13.3 per 10,000 live births. These variations can come from several differences across programs, such as included pregnancy outcomes, age at diagnosis, severity of cases included, and methods for collecting and verifying diagnoses. So limiting the group of included programs is intended to at least reduce some of that variability and include programs that we anticipate have more complete case ascertainment. And just a plug, next month, Tori Markwalter is going to present on the landscape of surveillance methods across programs, as reported on that performance summary that was collected last year, which will kind of quantify some of the programmatic variability. So the data analysis was pretty simple. We pooled the data across the 11 included programs for the 33 defects included in the previous estimates calculations. Prevalence per 10,000 live births was calculated using the pooled data for the 5-year interval. and by year, maternal race, ethnicity, and maternal age. In the past, national estimates were adjusted for race ethnicity. We did not adjust the estimates this year because we found some unusual results due to quite a bit higher than previous proportion of cases being reported in the unknown or other categories. We think that this might be related to the transition many programs are still making from bridged race methods to single race categories. But there could be other factors that we haven't considered as well. This is a topic we'd really like to discuss later with our colleagues in the network, particularly the Surveillance and Data Committee. We did calculate crude and adjusted estimates using the data from the last data call, and those results were very similar. So we felt okay about not adjusting this year. So now I'm moving into the results. In the data brief document, the estimates are presented in both figure and table format. They're organized by body system or group, and it starts with central nervous system defects. So among the three included CNS defects, spina bifida without anencephaly had the highest 5-year prevalence at 3.5 cases per 10,000 births. We don't include any comparisons to the previous estimates in the data brief document itself, but just for your awareness, I am including it in this presentation. The previous estimates are in the yellow bars and the current in blue. So there was no change in the prevalence of spina bifida and only very small changes for encephalocele and anencephaly from the last estimates, which were calculated with data from 2016 to 2020. And again, we are working on an analytic project to kind of more formally assess trends in prevalence. For each defect group, we included a chart showing the prevalence of each defect by year. For the CNS defects, prevalence was pretty stable over the 5-year period, particularly for encephalocele and spina bifida. The anencephaly prevalence looked to have a slight decreasing trend from 2018 to 2021, but increased again in 2022. We also included charts showing prevalence by maternal race ethnicity on the left and by maternal age, which is on the right. And among the CNS defects, births to Asian Pacific Islanders, shown here in yellow, had the lowest prevalence of these defects. The prevalence of anencephaly and encephalocele were highest among mothers aged less than 20, shown in the gray bars on the right chart, but were also relatively high among mothers aged 40 and over, which is in the purple. Spina bifida prevalence increased with increasing maternal age and was highest among births to mothers in that oldest age group. And I'll just mention here again that really our intent with this document was just to present the data that we have. We intentionally have not included any confidence intervals on these charts or made any conclusions in the document about prevalence being significantly higher in one group compared to another. The only eye defect included in these analyses was anophthalmia, microphthalmia, with a national prevalence of 2.1 cases per 10,000, which was very similar to the last national estimate. And the prevalence of this defect was quite stable over the 5-year period from 2018 to 2022. So looking at the maternal characteristics, births to Hispanics in red and American Indian Alaskan Natives in the darker blue had the highest prevalence. And the prevalence was highest among mothers aged 40 and older. The prevalence was very similar among all the other maternal age groups. Moving on to the cardiovascular defects, among the 16 that were included, Pulmonary valve atresia and stenosis had the highest prevalence at 11.3 cases per 10,000 births. And the next highest were for atrioventricular septal defect at 6.3 and coarctation of the aorta at 5.8 cases per 10,000. There weren't many substantial changes in the prevalence of cardiovascular defects from the previous estimates. There were increases for pulmonary valve atresia and stenosis and atrioventricular septal defect. Prevalence was stable over the 5-year period for most of these cardiovascular defects. There was a slight trend of increasing prevalence for pulmonary valve atresia and stenosis, which is this group here on the bottom. So looking at race ethnicity, for 13 of the 16 cardiovascular defects, prevalence was lowest among Asian Pacific Islanders. Again, that's the yellow color. The highest prevalence rates for all these defects were among either American Indian, Alaskan Natives in the dark blue, or Blacks in the light blue. The prevalence for all cardiovascular defects was highest among mothers 40 years and older. This finding was particularly notable for AVSD, which could be related to the association between that defect and Down syndrome. The next defect class is orofacial clefts. Among the three, cleft lip with cleft palate had the highest prevalence at 6.5 cases per 10,000 births. Cleft palate alone was very similar at 6.4, and cleft lip alone was lower at 3.5 per 10,000. Again, none of these prevalences changed much at all from the previous national estimates. Prevalence was fairly stable over the 5-year period. For these defects, there was a little bit of year-to-year variability, but overall, fairly stable. Looking at the maternal characteristics, the lowest prevalence for all three cleft defects was in Blacks. The prevalence of cleft lip with cleft palate and cleft palate alone were the highest among American Indian Alaskan Natives. And for all three orofacial defects, prevalence was highest among births to mothers aged 40 and over. So moving on to the gastrointestinal system defects, there were just two included. The national prevalence for esophageal atresia or tracheoesophageal fistula was 2.4, and that for rectal and large intestinal atresia or stenosis was 4.8 per 10,000 births. And again, we didn't see very substantial changes in prevalence for these defects from the last estimates. Looking over the 5-year period, 2018 to 2022, again, fairly stable, a little bit of a drop maybe in 2022 for esophageal atresia, tracheoesophageal fistula. For both gastrointestinal defects, prevalence was highest among births to American Indian Alaskan Native mothers and lowest among Black and Asian Pacific Islanders. For both, the prevalence was highest among births to mothers aged 40 and older, but was also high among mothers less than 20 years of age. Among the 5 included musculoskeletal defects, Clubfoot by far had the highest prevalence at 17.6 cases per 10,000 births. The next highest was limb deficiencies at 5.4 per 10,000. Overall, again, no big differences from the previous estimates. There was a decrease in clubfoot and an increase in limb deficiencies, but relatively small changes. Prevalence was stable over the more recent 5-year period for most of the defects. We do see a very slight trend of decreasing prevalence for gastroschisis. Births to American Indian Alaskan Native mothers again had the highest prevalence. That was consistent for all 5 musculoskeletal defects. And Asian Pacific Islanders had the lowest prevalence for all of these except diaphragmatic hernia. The prevalence of gastroschisis was highest among the youngest maternal age group and was highest among mothers 40 years and older for all of the other defects in the group. So lastly, among the chromosomal defects, trisomy 21, Down syndrome, had by far the highest prevalence at 16.1 per 10,000 live births. The prevalence of trisomy 18 was 3.2, and for trisomy 13, 1.5 per 10,000. Uh, no big changes in prevalence among the chromosomal defects from the previous estimates. Uh, Prevalence for trisomy 13, fairly stable. We maybe see a little bit of a decreasing trend for trisomy 18 and 21, but very slight. Looking at maternal characteristics, prevalence of trisomies 13 and 18 were highest among births to Black mothers. Trisomy 21 prevalence was highest among births to Hispanic and American Indian Alaska Native mothers. Prevalence did increase with increasing age for all 3 of these chromosomal defects, with particularly steep increases with age for trisomy 21. So just to kind of summarize, overall, among the 33 included defects, the highest prevalence estimates were for clubfoot, trisomy 21, and pulmonary valve atresia and stenosis. We acknowledge that there are defects that typically have higher prevalences, but those were not included in this analysis because they tend to have more variability in severity and surveillance methods, making the national data difficult to interpret. Prevalence was really quite stable over the 5-year period for most of the included defects. And we do have that more detailed trends analysis spanning a longer period in process where we will pay particular attention to those defects that showed possible changes in this analysis. Just to summarize the key findings around race ethnicity, American Indian, Alaska Natives had the highest prevalence rates for 20 of 33 defects, including all the musculoskeletal and gastrointestinal defects. Asian Pacific Islanders had the lowest prevalence for 20 defects, including all the CNS defects, 13 of 16 cardiovascular defects, and 4 of 5 musculoskeletal defects. And these findings are pretty consistent with previously published analyses. The key findings for maternal age were also not really anything new. So mothers 40 years and older had highest prevalence rates for almost all defects. The higher estimates were most notable among the chromosomal defects. And for three defects, anencephaly, encephalocele, and gastroschisis, the highest prevalence was among mothers less than 20 years of age. Births among youngest mothers also had relatively high prevalence of other musculoskeletal defects, so clubfoot and limb deficiencies. Um, for many of the defects, we observed kind of a U shape with the highest prevalences among mothers in the youngest and the oldest. So I just wanted to close by kind of outlining our planned next steps. We hope to publish the data brief to both the CDC and the network websites in early May. We will be working with the network to coordinate program approvals and posting of the state PDF tables. The annual trends assessment using these data and previously collected data is underway. Um, the Surveillance and Data Committee will be discussing any additional analyses and future products to be completed with these data. CDC and NBDPN have already started planning for the next data call, which is anticipated next year. And then finally, we have plans to revisit the current methods used to generate the national estimates. We'd really like to be able to include more programs data since all this work is going into collecting and reporting, and we'd like it to be kind of a broader representation. We'd also like to be able to generate estimates for a broader group of defects, but both of these things are going to require kind of some more discussion and evaluation with the Surveillance and Data Committee and the programs themselves. Also, as I mentioned a little earlier, we would also like to discuss kind of the best ways to approach race and ethnicity adjustments in the future, given kind of the increasing complexities that we're seeing with the data, at least as collected currently. So as I close, I just wanted to really thank the Surveillance and Data Committee for their assistance coordinating the data collection that the results are based on. And of course, we very much thank all the birth defect surveillance programs and the analysts and epidemiologists that collected and provided the data.